Subscribe now and press the bell icon. Never miss an update.
Today's interactive session on diseases of the stomach. Today's discussion about the part 2. So the topic is upper gastrointestinal bleeding. Upper gastrointestinal bleeding is called the bleeding from any part above the ligament of Treves. That means the duodenojejunal junction is regarded as upper gastrointestinal bleeding. That means from fourth part junction of the jejunum and duodenum, from there upwards anywhere bleeding in the GI tract is called the upper GI bleeding. It may be presented as hematemesis or melena. What is hematemesis? Hematemesis is the vomiting of blood from the upper GI tract. When the vomitus mixed with blood mixed with vomitus, then it is called hematemesis. So the bleeding is very early, came out from the stomach to the exterior. For that reason, it is a bright red blood. And clots imply active bleeding and are a medical emergency. And sometimes altered blood with a dark granular appearance, coffee ground appearance, suggests that bleeding has ceased or relatively modest. This is converted to acid hematine by gastric hydrochloric acid. That means when the vomitus mixed with fresh blood, it indicates there is active bleeding now. But whenever the vomitus mixed with altered blood to some extent dark granular appearance, then it indicates that the bleeding is not massive amount now. The bleeding may be ceased. The stomach containing blood is altered there to some extent and came out exterior. So mixed with hydrochloric acid is converted into hematine, which is causing dark granular appearance of the vomitus. Melena, that means passage of black, tarry, sticky stool. It is very important thing is black, tarry, sticky stool. This stool must be sticky. It is soft in nature, not hard black stool. Never ever melena. Be careful about it. Whenever the melena asks in the exam, what is melena? Your answer is it is passage of black, tarry, sticky stool. Sticky must be mentioned. And it resembles like a tarry. For that reason, it is already whenever the tarry appearance, it is a sticky. So black, tarry, sticky stool is called the melena. What are the causes of upper GI tract bleeding? Lot of causes are listed there. Among them, ulcers is 60% of the cause of bleeding. So the ulcer may be in the esophagus, or maybe in the gastric, or in the duodenum. The esophageal ulcer is 6%, gastric is 21%, and duodenal ulcer bleeds is 33%. And erosions, it may be in the esophagus, or in the gastric, or in the duodenum. And another important thing is a Mallory Weiss tear. The tear is occurred in the muscle mucosa at the junction of the stomach and the lower end of the esophagus, and it causing massive bleeding there. And esophageal varices, it is also an important cause. Esophageal varices, that means tortuosity dilatation of the vein in the esophagus, which is called esophageal varix. Then tumor. Tumor usually is the malignant one. Sometimes some benign tumor like previously, which is called the leiomyoma of the stomach. Nowadays it is called the gist. There is an ulceration in the surface and presented as a bleeding. So tumor is causing bleeding presented there. And some vascular lesions called the Diel-Foys disease. and others is 5%. So these are the causes of bleeding in the upper GI tract. What about the management? So management is an emergency management needed whenever there is a bleeding. So there is a blood loss. So the blood loss causing decreased blood volume. So whenever the blood volume is more markedly declined, the patient may turn into shock. For that reason, early notice the patient, early resuscitate needed. So emergency management needed. Whatever the cause, the principle of management is identical. That means first the patient should be adequately resuscitated, and following this, the patient should be investigated urgently to determine the cause of the bleeding. Initially, don't searching about the bleeding cause. Initially, you resuscitate the patient. Then you search the etiology of the bleeding. Only then should treatment of a definitive nature is instituted. For any significant gastrointestinal bleeding, the intravenous access should be established, and for those with severe bleeding, central venous pressure monitoring should be set up and bladder catheterization performed. So if you put a central venous catheter, you can easily measure the volume of the central venous pressure. If central venous pressure is low, so there is a low blood volume. So needed more resuscitations. If the urinary output is less, it indicates the patient having the volume, blood volume is also decreased. So the vasoconstriction is there, renal perfusion is declining, and the urinary output is declining. So for that reason, that two parameters can dictate you what about the hydration status of the patient is. Blood should be cross-matched. Whenever you open a channel, blood is taken for grouping cross-matching and establish the channel with the IV fluids to maintain the access, to maintain an access to whatever you infused, you can infuse by this channel. For that reason, channel is established there. Blood should be cross-matched and patient transfused as clinically indicated. Usually, when more than 30% of the blood volume has been lost, immediately the patient needs to blood transfusions. As a general rule, most gastrointestinal bleeding will stop. It is very important thing is, lot of bleeding occurs most of the patients, but they are spontaneously stops, albeit temporarily, but there are sometimes instances when this is not the case. In these circumstances, resuscitations, diagnosis, and treatment should be carried out simultaneously. There are occasions when life-saving maneuvers have to be undertaken without the benefit of an absolute diagnosis. In patients with non-esophageal varices and uncontrollable bleeding, a sense-taken Blackmore tube may be inserted before an endoscopy has been carried out. This practice is not to be encouraged except in extreme cases. So this is a sense-taken Blackmore tubes. The tube having a multiple balloons, one in the tip, another one in the shaft. The shaft end can make the pressure over the esophagus varices, and the stomach balloon can compress the stomach mucosal wall and causes erythemolysis. So this is a very favorite for the previously, but nowadays it is not used properly, usually. So in patient with non-esophageal varices and uncontrollable bleeding, in that case it may be introduced. But this practice is not to be encouraged except in extreme cases. In some patients, bleeding is secondary to a coagulopathy. The most important current causes of this are liver disease and inadequate controlled warfarin therapy. So there is a chance of bleeding there. In these circumstances, the coagulopathy should be corrected, if possible, with fresh frozen plasma or concentrated clotting factors. So you can correct the coagulopathy spontaneously, the bleeding can arrest. Upper GI endoscopy should be carried out by an experienced operator as soon as practicable after the patient has been stabilized. And during that upper GI endoscopy, the sucker machine must be, strong sucker must be needed. Otherwise, the blood clot are not capable to expel out from the stomach to the exterior. If the blood clots are not removed, you don't able to identify the bleeding site. A number of scoring systems have been advocated for the assessment of rebleeding and death after upper gastrointestinal hemorrhage. Perhaps the most useful of these is the Rockwell score. So these are the various scoring system to evaluate the seriousness of the patient is. So the treatment management is treatment algorithm for upper GI bleeding. Whenever the patient is admitted, assessment of circulatory state. If patient no shock, in that case diagnosis by endoscopy within 24 hours. If the patient is in shock, there is less than BP 110, blood pressure pulse rate is more than 110, and urgent resuscitations, then observe if the bleeding is the condition is stabilized, then after 24 hours go for diagnosis with endoscopy. If the condition is deteriorating, continued bleeding, then emergency endoscopy is needed, and that bleeding identified and treated endoscopically. Bleeding overwhelming and cannot be controlled endoscopically. Only then in that cases go for the surgical emergency surgery. So emergency surgery is very little rule nowadays because the endoscopy facilities is available and lot of the parameters they can achieve arrest hemorrhage by various techniques like clipping, diathermy, phototherapy, etc., various laser therapy, etc. For that reason, nowadays the surgical emergency is very least requirement. Diagnosis by endoscopy within 24 hours. If there is an ulcer, so ulcer there is bleeding, you can inject sclerosing agent, you can apply some diathermy or heater probe or by infrared sometimes they prescribe, or if rebleeds, consider surgery. So when the endoscopy measurement is failed, then you go for the surgical treatment. And what about the varices? The varices, there is a dilatation of the vein in the lower esophagus, so that having some injection sclerosing may apply there, or the Barron's bending, not Barron's, bending facility is available, then you can ligate with the bend. And again, there is a repeat endoscopy procedure, again bending, or if failed, then you go for surgical treatment. Other usually pursue conservative management. Now we discuss about the gastric neoplasm. So that neoplasm may be a benign one or the malignant one. The benign lesion are the gastric polyp or gastric adenoma. So it arises from the epithelial tissue. So whenever it is a metaplastic polyp, it is associated with H. pylori infection. If it is inflammatory polyp, histopathology report, so it is a benign one. If it is a fundic gland polyp, so none of the above polypoid lesions have malignant potential, but may turn into the malignancy. No have malignant potential, but also to some extent may go into malignant. Gastric adenoma, these have malignant potential and should be removed. If the patient having gastric adenoma, endoscopy diagnosed, you can take the biopsy from there. The diagnosis reveals there is gastric adenoma, so that adenoma must be removed, but there is a more chance of subsequent malignant transformation. Mesenchymal tumor like leiomyoma or lipoma. These are the two benign lesions, may presented as a tumor-like lesions within the stomach. So in the malignant one, the primary one is the adenocarcinoma, which is the commonest one. Some gastrointestinal stromal tumor, that may have a malignant transformation, and some has a lymphoma and carcinoid tumors. And the secondary one, invasion from the adjacent structures, like the pancreas or the gallbladder or other structures. So these are the gastric neoplasms. So among them, we now discuss about the gastric carcinoma. Introduction. It is one of the most common cause of cancer death in the world. Very important line is, it is the most common causes of cancer death in the world. The incidence of gastric cancer is more in Japan, and gastric cancer is actually an imminently curable disease provided that it is detected at an appropriate stage and treated adequately. It is important thing it is. It is a curable disease provided it is diagnosed earlier, staged properly, and do the surgical intervention. Then the result outcome is well and good. Early diagnosis is therefore the key to success with this disease. The only treatment modality able to cure the disease is resectional surgery. That means surgery is the best options of the carcinoma stomach treatment. So there are two pictures is given there. One is normal position of the stomach, then level the lymph nodes surrounding the stomach are. And that below picture is remove the stomach from the field and look about the under surface of the stomach. There is a lot of lymph nodes also there. So that lymphatic drainage you must know, because a lesion in the stomach, there is a more potential to migrate metastasis to the lymph nodes or the regional groups of lymph nodes. So the lymph drainage always from the stomach lesions, the draining lymph nodes is perigastric lymph nodes. So look, there is a left gastric artery, right gastric artery, and the right gastroeploic artery, left gastroeploic artery, and the short gastric vessels. So the lesions where from there they migrated on the vicinity of the lymph nodes. For that reasons, the lymph node drainage must know. Otherwise, during surgery, if you don't know the lymph node drainage, you cut the tissues. So there is a lot of lymph nodes remains there. So the disease metastasis tissue remains in the lymph node. From there, they go on the proximal lymph nodes, and ultimately distal metastasis there. For that reason, the draining lymph node status must you know. Otherwise, you don't able to do the curative surgery. That means whenever you remove the perigastric lymph nodes along with the stomachs and block, then it is called the D1. When the lymph nodes in proximal to the upper groups, then it is D2. Then whenever the more groups of lymph nodes you taken out more centrally, then it is called D3. These are the radical surgical steps. So whenever a patient having a lesion in the stomach, no mucosa, limited to the mucosa and submucosa, no lymph node metastasis, that means the lesion is there. So if you remove the stomach, it is sufficient. But if you remove the, along with the lesser and greater curvature lymph nodes, so it is more curable, because you can become sure after histopathology, no lymph node having a metastatic cells there. So it dictates this, your radical surgery is done. So these are the lymph node levels. Those are written here: right cardiac, left cardiac, lesser curvature, proximal curvature. These are lot of lymph nodes are marking among them. These are the levels. So this is about the lymphatic draining. What about the etiology? So whenever the malignancy develop in the stomach, that having some etiology may underlying there. So the gastric cancer is a multifactorial disease. No unique cause lying underneath the gastric carcinoma. The etiology factors are nowadays Helicobacter pylori, most important etiology, infection. Don't treat it properly. Long time exposure there, so there is chance of carcinoma stomach. And whenever a patient have a pernicious anemia, so there is a gastric atrophy, there is chance of malignancy there. Gastric polyp, there is chance patients having history of Builder 2 or polyagastrectomy, gastroenterostomy or pyloroplasty. So all of the procedure causing reflux of bile to the stomach of the remaining part, there is irritation and there is chance of malignancy in the remnant of the rest of the part of the stomach. So duodeноgastric reflux or reflux gastritis, also there is chance of metaplasia ultimately go into the malignancy. Intestinal metaplasia, there is chance of malignancy. Cigarette smoking, dust ingestion from a variety of industrial process, those all of them are predisposing factors for development of carcinoma stomach. Ingestion of spirits, in excessive salt intake, ingestion of smoked food. So in China, in Japan, they are more oriented to smoked food. So it is one of the cause, and another one is they are more oriented to preservative foods. So that food preservatives also causing carcinoma stomach development etiology. So deficiency of antioxidants and exposure to N-nitrosamine compounds. That N-nitrosamine compounds are, in case of preservative of the foods, it is present. This is the cause of carcinoma stomach development. And another one is genetic factors. If the blood group is A, on starting, it is proved that blood group A having a more potential to develop carcinoma stomach. So these are about the etiology of carcinoma stomach. So the pathophysiology, H. pylori infection. So that causing superficial gastritis. There is ectropic gastritis, intestinal metaplasia, dysplasia, and ultimately development of cancer. So sites of cancer, it may be in the cardiac end, it may be in the body, or it may be in the antrum or in the pylorus. So in the study proved that the cardiac end is 17% too high, and body is 15%, antrum is 13%, and pylorus is 7%. So among the parts, there is more in the cardiac, then in the body, then antrum, then pylorus. So these are about the sites of percentage of site of malignancy in the stomach. What about the gastric carcinoma is classified on the basis of carcinoma stomach is classified on the basis of depth of invasion, how far it penetrates, and macroscopic growth pattern. On external macroscopic findings, what is the pattern of the lesion is, and histological and pathological classifications. So on the basis of depth of invasion, there is two types. One is early gastric carcinoma and advanced gastric carcinoma. So cancer is limited to the mucosa and submucosa with or without lymph node involvement. It is very important thing because that is frequently asked in the exam. What do you mean by early gastric cancer? That means the stomach is in mucosa, submucosa, muscle coat, and peritoneum, serous coat. So whenever the lesion is limited to the mucosa and submucosa, then your answer is early gastric cancer. But here additional term is added, with or without lymph node. The lesion is not involved the muscle coat, but the lesion is also metastasized to the lymph node. So the lymph node is immaterial if the muscle coat is not involved. That means we only limited to the mucosa and submucosa. With or without lymph node, the diagnosis is early gastric cancer. Be careful about the term. Limited to the mucosa and submucosa with or without lymph node involvement. It is called early gastric cancer. There is a classification system for early gastric carcinoma known as Japanese classification. They are more prone to develop carcinoma stomach. So they are more studied there. They are more advanced to treatment of the carcinoma stomach. They are having a protocol. There is always they are prophylactically do endoscopy in elderly patient. There is a protocol there for early diagnosis of the early carcinoma. So if the diagnosis early treat, so the patient cure early. For that reason, the Japanese, there is a special classification, early gastric carcinoma. Advanced gastric carcinoma, when the carcinoma spreads beyond the submucosa. So the muscle coat, whenever touches the malignant cell, it is advanced malignancy. So in that case, they don't bother about the lymph node. But here, In case of early gastric cancer, there is the mucosa and submucosa is the main factors. It is early or not. There is a classification system of the early gastric carcinoma known as Borman classification. So in Japanese classifications, there is three types. One is type 1, type 2, and type 3. Type 2 again divided into 1, 2, 3 variety, A, B, C. And 3, there is no other classification. So on a type 1 and type 2. Type 2 is the 3 and type 3. So type 1 is when the lesion is protruded towards the inside of the lumen. So protrusion of the tumor mass into the lumen, it is mucosa involvement. It is type 1. Type 2 is superficial, in which there is no tumor mass into the lumen. There is no protrusion like this protruded. There is a, in which no tumor mass into the lumen, mucosa involvement. This means type 2A, it is just elevated. Type 2A, just elevated. Type 2B, it is flat. And type 2C is depressed. That means elevated, flat, and depressed. So easy memorize that technique. First is elevated, then plain, then flat, then little bit depressed. And lastly is a type 3 is the excavated, where a shallow deep ulcer crater is present in the wall of the stomach, mucosa and submucosa involvement. This type of cancer is imminently curable. And even early gastric cancer associated with lymph nodes involvement have 5-year survival rate, which is 90%. Be careful about it. 5-year survival rate is about 90%. So this is about the Japanese classification. What about the Borman classification? It is 4 types. This type 1, it is fungating or polypoid. Type 2, ulcerated. Type 3, infiltrative. So look, there is some infiltration is there. And type 4 is diffuse and linitas plastica. So type 3 and type 4 are incurable. Be careful about it. So there is the infiltration. So it can already migrate, so proximal and distally there. For that reason, these 2 types are incurable. So that linitas plastica, it is also important one because it is involvement the mucosa, submucosa muscle coat. So the stomach wall become harder. So during endoscopy, it is very difficult to diagnose in case of linitas plastica because it is infiltrate the inside. In the mucosa, it looks like a normal one, but only the caliber is too small. If you inflate with the endoscope, the stomach is incapable to distend it. So it is the only reminding sign the patient may having a linitas plastica type of carcinoma stomach. So this is better to diagnose by looking the CT scan, not by endoscopy. But the other 3 can easily diagnosed by looking the endoscopic picture. Look, introduce the endoscope, look there, polypoid, take the biopsy. If there is ulcer, take the biopsy. So you can confirm your diagnosis that the patient having a malignancy there. But in case of linitas plastica, the mucosal surface may be normal looking, so very difficult to diagnose. If you take a deep bite by biopsy forceps, in that cases you can capable to confirm your diagnosis that the patient having malignancy in histopathological probe. But your diagnosis is usually confirmed. We look the CT scan, then you can more or less sure the patient having a linitas plastica. So Lauren classification was the histological type. The 3 types: intestinal gastric carcinoma, diffuse gastric carcinoma, and mixed morphology. It arises in areas of intestinal metaplasia to form the polypoid tumors or ulcers. Prognosis is good. Whenever the metaplasia in intestinal types and turn into malignancy, the prognosis is good. But in infiltrate it, in case of diffuse gastric carcinoma, it infiltrates deeply in the stomach without forming obvious mass lesions, but spreads widely in the gastric wall. Very careful about it. So that is called the linitis plastica. Prognosis is worse because the patient is present to you lately. There is no mechanical obstruction, so there is less symptom. So for that reason, the prognosis is worse. And some are mixed morphology. This is called the Lauren classification. So in early cases, it is difficult to diagnose disease early due to time lag between the commencement of the growth and the appearance of symptoms. So only one thing is always remember: new dyspepsia after 40. It is very favorite term for every examiner. So that is their answer. New dyspepsia after 40, most likely the patient having carcinoma stomach. You must do an endoscopy and confirm that is there any lesion or not. So mild new dyspepsia after 40, it is the main symptom. Back postprandial abdominal fullness, anorexia, malaise, early satiety. These are non-specific one. Only alarming sign is new dyspepsia after 40. Be careful about it. Common clinical presentation is 3A: anemia, anorexia, asthenia. That three can dictate you the patient need to do an endoscopy to evaluate the stomach. The patient may having carcinoma stomach there. In advanced cases, whenever the patient will linitis plastica, so the caliber of the stomach is smaller. So whenever the patient ingested to some extent of food, the patient's stomach is full, there is a chance, there is a reflux stimulation and causing no need to further intake. For that reason, early satiety is there. And bloating, abdominal distension, epigastric pain, but the pain is persistent, not responding to H2 blocker or proton pump inhibitor. Obstructive features sometimes present whenever the lesion in the antrum of the stomach. So vomiting if carcinoma involves the pylorus presents as gastric outlet obstruction, persistent, contain food materials. And dysphagia is presented when the lesion lies at the cardiac end of the esophagus. So cardiac end of the esophagus presentation is dysphagia. And antrum of the stomach or pyloric end of the stomach malignancy presented as a vomiting. So these two is very alarming sign for diagnosis of stomach carcinoma. So another two thing is loss of appetite. It is also important one, loss of appetite. Whenever the patient presents to you loss of appetite, it is always a alarming sign. The patient may having an undiagnosed malignancy. Not only the stomach, carcinoma, pancreas, other malignancy also loss of appetite. And weight loss, it is also an important sign that you must examine the patient may having any malignancy there. And always look weight loss sometimes in diabetes, uncontrolled diabetes also in weight loss. So if a patient having a malignancy with the diabetes, so sometimes mislead that the weight loss due to the diabetes. So though the patient is diabetic, whenever there is a weight loss, you must evaluate the patient with an endoscopy, must. Clinical manifestations, sign. In advanced gastric carcinoma, these are markedly present only: unexplained anemia, cachexia, palpable epigastric mass. That palpable epigastric mass, whenever the patient present to you lately, there is a mass filled there. Or whenever the patient having a gist, usually it is larger in size, and exophytic gist usually protrude outside the lumen, lately may patient present to you. For that is in case of palpable mass, you notice, then you can evaluate by doing an ultrasonography what is the lesion is. Sign of metastasis, it is very important thing is the lesion in the abdomen, within the stomach, but the lesion may migrate in the distal organ, distal part of the body, like left supraclavicular lymph nodes. So in general examination, for that reason, we always examine the left supraclavicular lymph nodes. It is enlarged or not. That enlarged lymph nodes dictates you lot of causes of enlargement there. That enlargement may be lesion in the gallbladder, lesion in the stomach, lesion in the pancreas, and lesion may be in the carcinoma prostate, may metastasis in the left supraclavicular nodes, and left side of the chest cavity, any malignancy may metastasis there. So that left supraclavicular lymph node enlargement can dictate you the patient may having anywhere may be having a malignancy there. So search the patient thoroughly, examine the patient, investigate the patient, then you can diagnose why the lymph node is enlarged and what is the primary site. So that enlargement is called the Barkhouse node. The sign is called the Troyer sign. Sometimes asked in the exam, sometimes asked in the long case, sometimes in the short note. So in that case, you must write that palpable left supraclavicular lymph nodes. It's called the Troyer sign in case of carcinoma stomach. Jaundice due to hepatic involvement or lymph node in the porta hepatis enlarge the metastatic nodes and press they are causing obstruction, or they throw blood-borne metastasis to the liver and causing the jaundice, and ascites due to metastasis to the peritoneal cavity. And another one is very important thing is Sister Mary Joseph nodule. Sister Joseph nodule. Sister Mary Joseph nodule. It is a very important sign of metastasis. It occurs in the umbilicus. Through the falciparum ligament, there are metastasis in the umbilicus, there is the nodule. If you do an FNSE, you can confirm that the patient having adenocarcinoma. Then do an endoscopy, you can diagnose that the patient having carcinoma stomach. So carcinoma stomach, metastasis in the umbilicus, which is called the Sister Joseph Mary Joseph nodule. So always, whenever any lesion in the umbilicus, you exclude it is a hernia, or it is a malignant deposition, or it is a abscess in the umbilicus. That three things must be confirmed, differentiate by doing some investigation. Like one is FNSE. By FNSE, you can easily confirm that there is a metastasis or abscess. Or do an ultrasonography, you can confirm that there is a gap or not. So if there is a gap, there is a momentum may protrude out, or the intestine is protruded out, it may be a hernial swelling in the umbilicus. So always remember, look the stomach pathology presented in the umbilicus, which is called Sister Mary Joseph nodule. Other signs of metastasis. So all the findings always memorize, because during examination of a long case, you must all the points. Otherwise, you can miss some of the metastatic sign. So whenever the cancer cell is detached from the stomach to the peritoneal cavity, so the patient can move, walk, sit, sitting, lying. So that movement causing the detached cells is migrated down in the dependent part of the body. That means in the pelvic cavity, in the rectovesical pouch or rectouterine pouch there. So that deposit cell multiply there and creating a lesion, mass effect there. That lesion can felt by your finger on the rectum, which is called the Bloomer shelf. That means metastatic spread to pouch of Douglas found in the DRE. There is another layer of deposition of the cells you can felt. There is a hard, thin lesion in the pelvic floor, which is called the Bloomer shelf. Some lesion sometimes is called the Irish node, enlargement of the left axillary node. Sometimes very rare. And very important and very favorite term is the Krukenbar's tumor. Sometimes in the written exam, sometimes in the viva, the Krukenbar's spelling you must look carefully. Krukenberg. So this is very important to know everybody, because it's a very favorite term most of the surgeons, and which occurs in the metastasis to the ovaries. That means whenever the carcinoma stomach presented along with the ovarian tumor, then your diagnosis, it is the patient having a Kuchenbach tumors. But the confirmation is done after doing the histopathological report. If the ovarian lesion is a signet ring in appearance, then the cell is mimics with the stomach malignant cells, then your diagnosis is confirmed it is a Kuchenbach tumors. But if the patient having a dual pathology like a new ovarian cancer in the ovary and carcinoma stomach and a separate one, is that this is not the Kuchenbach tumors. So Kuchenbach tumors is confirmed after histopathological examination. The histopathological reports findings is it is signet ring appearance there. One-sided the nucleus puts there, then the signet ring inside the is a vacuum there, so which is called a signet ring appearance. And the Kuchenbach tumor does not develop in all the age groups of the bleeding, because whenever the malignant cell is deposited, they are always searching that where there is more blood supply, more nourishment is there, so they can easily settle there, easily multiply there. This is the tendency of the malignant cells. So whenever a malignant cell detaches from the stomach serous surface, then it descends down to the pelvic cavity. If the patient is menstruating lady, so there is a chance of ovulation. So during the ovulation, the surface of the ovary become rough. There is a ovulation, there is a capsule is tear, the ovum may expel out. So that raw surface can adherent with the malignant cells and deposited there, multiply there, creating a big ovarian tumor there. Then it is called the Kuchenbach tumors. But in case of postmenopausal lady, the ovary is atrophied. There is no raw surface there, so there is a less chance of development of Kuchenbach tumors. So Kuchenbach tumor is developed in a fertile lady where there is ovulation, there is a chance of deposition of cancer cells which is detached from the stomach, depend down to the pelvic cavity and adherent there, multiply there and grow there. So this is called the Kuchenbach tumors. Another one important thing is there is a lymph node left is called the Troyer sign. There is another Troyer sign. So that is spelling sometime asked in the exam. Trousseau''. So this must be know everybody, but sometimes in the viva they ask. And this is phlebothrombosis of the superficial base of the leg. When a malignancy present with a phlebothrombosis, superficial vein becomes thrombosed, then it is called the Troyer sign. So that two sign must know everybody. TT, for that reason, they are very similar to spelling. So for that reason, must know what is Troyer sign, what is Troyer sign. So these are about the clinical manifestations. So how it is spread? So all the malignancy having a definitive pathway to migrate from a definite site on a distant site. So that pathways are direct spread. So whenever it infiltrates the surrounding viscera, it is called the direct spreads. So this is direct spreads adjacent structure like pancreas, colon and liver. There is a lymphatic spreads. Through the lymph vessels, they migrate to the supraclavicular nodes and others. There is whenever the vein are involved, the malignant cell go inside the vein, go to the liver. So there is a liver ultimately go to the lungs and bones. So whenever the cell is detached, tumors can manifest anywhere in the peritoneal cavity, commonly give rise to ascites. The ovaries can sometimes be the sole site of transcelomic spread, Kuchenbach tumor. Some are additional, which is not written here, that are transneural migration. Some having a transluminal. The luminal migrate go proximally or distally. So these are the mode of spread of malignancy of the stomach. In which age Kuchenberg tumor is common? I discussed it there. During the reproductive period, rupture of the luteal cyst during the ovulation period and produces a row surface in the ovary. So the transluminal spread occurs, malignant cells deposited row surface ovary and produces the Kuchenberg tumors. It may be unilateral, it may be bilateral one. And another important thing is not at the same time develops the both sides, because the ovulation having occurred in a alternate manner. 1 month on the right side, on the next month on the left side. Again on the right side, then on the left side. So in this month the cells is deposited here, they multiply there. On the next month or subsequent after 2 months, on that case there is deposition is there. So there may be single tumor or there will be bilateral one. So staging depends upon the T for tumor, N for node, M for metastasis. So these are the tumor TNM staging. So the T means thickness, involvement of the thickness of the wall. So there is a, in case of carcinoma in situ, only it above the basement membrane. Whenever the mucosa and submucosa T1, when the muscularis propria is T2, when the T3 tumor involves the subserosa, and T4 a tumor perforates the serosa, T4b tumor invade the adjacent organ. So that is same as the regional groups of lymph nodes. No lymph node, metastasis 1 to 2 regional groups, 3 to 6. When 3A metastasis is 7 to 15 regional nodes, and metastasis is more than 15 regional nodes. And metastasis, no distal metastasis, or M1 is distal metastasis. So this is TNM stage. So what investigations? Diagnosis made by the single best investigation is upper GI endoscopy with biopsy. So this is very important one. Upper GI endoscopy. That means you put an endoscope through the mouth to the esophagus and go to the stomach, and after the duodenum you can look. Is there any mucosal ulcerations or any growth, any protrusion is there? So whenever there is ulceration or protrusion, then your aim to take the biopsy from the site. The biopsy must be multiple site, because if you don't take the biopsy multiple site, the 1 or 2 samples may be missing your diagnosis. There in the 2 samples there is no malignancy there, but in the 3rd or 4th sample there is a malignancy. For that reason, the biopsy is multiple site biopsy is needed. Whenever is suspected ulcer, they are always take the biopsy in the normal and unhealthy area. But in case of endoscopic biopsy, it is very delicate, because the forceps is so small that small tissue is taken by the biopsy. For that reason, very seriously take the biopsy. Otherwise, there is chance of miss the diagnosis. Whenever the diagnosis is given, there is no ulcer, no malignancy, then they treat the patient as a benign gastric ulcer or benign duodenal ulcer. For that reason, biopsy is very important to take histopathological examination. Another investigation, double contrast barium meal X-ray of the stomach and duodenum. This is normal, we do the barium meal X-ray of the stomach and duodenum. But that term is written there, double contrast one. It is very important thing is. So double contrast meal, there is a 2 contrast, one is barium and another is air. So in case of double contrast barium enema, through the anus, we put some air by inflate with the inflated balloon. We press it and make a pressure, so some air is go in the rectum and go to the colon, so that gas can the barium become more compressed, pressed and lying over the mucosa, so very cleanly the mucosa can inspect. For that is on double contrast barium enema done. But in case of barium meal, there is no scope to put the air, because the patient is ingest with the glass of water. So there is not too much air is possible to deglute it to swallow. For that is in case of double contrast barium enema, some effervescent tablet they mix with the barium. So that effervescent tablet can produce some gas inside the stomach. So that gas can disseminate the barium throughout the mucosa. So easily can delineate. So for that reason, it is called the double contrast barium mill X-ray. Here, the air gas is produced by some effervescent tablet. What about the staging? The staging done by some other investigation. The very common one is ultrasonography one. So you can look the periodic groups of lymph nodes. You can look the liver, and you can look the patient having necrocancer tumors or not, ascites or not. All the information you can gather by looking at a very simple test is ultrasonography. But the ultrasonography don't able to diagnose the tissue diagnosis. So tissue diagnosis is confirmed before doing a surgical intervention. So tissue diagnosis is confirmed by biopsy, and other investigations like ultrasonography too can ascertain you what about the involvement of the lesion is, how far the disease is spread. You can guess by doing an ultrasonography. And another was CT scan of the abdomen, MRI. These two investigations is a very important tool to look about the lymph node status, liver status, etc. Chest X-ray also do the any metastasis you can look. Is there any pleural effusion you can look? Liver function test can dictate you if there is a liver metastasis, there is a liver function altered. But in case of bone metastasis, you can do in bone scan, you can evaluate there is a bone metastasis or not. Some tumor markers also very important roles take part. It is, though it is non-specific, but it is a prognostic value. Because if you do the tumor marker before surgery and after surgery, after 2 months or 3 months or 4 months, if you follow up the marker, if it is rising, it indicates that the surgery is not curable. Again, there is a recurrence. So you can early detect there is a recurrence is there by observing the tumor marker. So that tumor marker is commonly CEA, carcinoembryonic antigen. Sometimes ask in the exam, what is CEA, carcinoembryonic antigen? We remember about it. The others are CA99 and CS72-4. These are the tumor markers specific for CS stomach, not only CS stomach, but also the GI tract malignancy. And previously, for staging, they do some laparoscopy. But nowadays, it is very limited. Don't need for laparoscopy for staging. All the investigator can easily make the staging. So no need for laparoscopy. But it is a previously, whenever the laparoscopy is not too familiar, in that cases, they are only do for laparoscopy. But nowadays, laparoscopy is the surgical curable treatment done. It is not for the staging. It is for the treatment, surgical treatment policy needed. Say other investigation, routine investigations like CBC, the patient having anemia, so there is a decreased hemoglobin, so you can monitor what amount the hemoglobin is if needed to go blood transfusion for surgery. And what about the blood sugar? The patient diabetic, elderly patient is usually developed. For that reason, the patient mostly having diabetes. So if the diabetes or not, if the diabetes, you must need to control it. And renal status also need any source of surgery. You must evaluate the renal function because lot of medications during anesthesia, during surgery, after surgery, all of the causing some nephrotoxic drugs. If the patient having a preoperative renal compromise, it may deteriorate and may convert into the renal failure. For that reason, always do a serum creatinine level need for evaluation of the renal status. What about the upper GI endoscopy? It is the gold standard investigation. Gold standard investigation. Multiple biopsies, 6 to 7 or more, are taken for accuracy. Look at the picture. That picture, there is some dead tissue is there. If you take the biopsy from here, the tissue is not significant. There is no malignancy seen. But if you take the tissue from the junction between healthy and unhealthy tissues, there is a more chance of diagnosis of the malignancy. And cytological brushing can also be obtained for early diagnosis. And size, morphology, location of the tumor can assess. Because by doing the endoscopy, you can evaluate it is lesion in the cardiac end, or in the cardiac pyloric end, or in the body along the lesser curvature or the greater curvature. All the information you can guess by looking the endoscopy. So endoscopy can dictate you what type of surgery you needed further. So this is double contrast barium enema, barium mill. That means AR and barium. So the barium can easily delineate the lesions. So there is irregular filling defect is there. But always remember, whenever a lesion in the pyloric end or antrum, so it is outlet obstruction. But in case of carcinoma stomach, the stomach is not too much dilated. But in case of peptic ulcer disease, pyloric stenosis, there is a chronic duodenal ulcer disease. So scarring is a slow process, gradually narrowing of the lumen. So there is an adaptation. So there is a more stasis of the food materials. So there is a more dilatation of the stomach. So in comparison to the pyloric stenosis and carcinoma antrum, the stomach in case carcinoma stomach is not too much dilated. But in case of pyloric stenosis, the stomach is hugely dilated. This is the basic difference because it takes time, long years needed for cicatrization and narrowing. But in case of malignancy, very rapidly can lumen obliterate. So there is no adaptation of the stomach. So there is no chance of dilatation of the stomach more. So this is the irregular filling defect in the drum. Most likely it is persistent filling defect. So that term is very important one, persistent filling defect. That indicates the peristalsis having a filling defect there. So for that reason, you must need it to evaluate the subsequent film. If all the films or 2 or 3 films as a fixed area, there is a filling defect there, then your diagnosis is a carcinoma stomach, irregular persistent filling defect. But if one film is there, but after 1 minute film, there is no filling defect there, indicates that it is a peristalsis. For that reason, the term is written there, persistent filling defect. So be careful about it. Irregular persistent filling defect dictate that the patient having a malignancy. Loss of rugosity. There is a rugosity there. So there is a rugosity, there is no rugosity is there. And delayed emptying because there is obstructions. Lumen is like that, but it narrows, thin space there. So dilatation of the stomach in carcinoma pylorus. Not more marked, but to much extent dilated. But narrow and indistensible stomach, lineatus plastica. And margin of the lesion projects outwards from the ulcer lesion into the gastric lumen, which is Carmen meniscus sign. Whenever protruded out, then it is called Carmen meniscus sign. What about the differential diagnosis? So, differential diagnoses are gastric ulcer, other neoplasms, gastritis, gastric polyp, Crohn's disease. So, all things can be evaluated by doing an endoscopy. You can easily evaluate taking the biopsy, what the lesion is. So, gastric ulcer, from the history, you can take ulcer history, and pain is not relieved by antacid in gastric cancer. Pain is not periodic in gastric cancer. Pain is not relieved by eating or vomiting in gastric cancer. So, other like gastritis, gastric polyp, Crohn's disease, these are rare. Crohn's disease is rare in the stomachs. What about the management? The management is a pre-operative preparation, then surgery, then chemotherapy, then radiotherapy. But having the chemotherapy, there is another term, is a new adjuvant chemotherapy. Nowadays, previously we are more oriented about the first prepare the patient, go for surgery, after giving the pathological report, marginal clearance, then send to the oncologist, they give the chemotherapy, and the treatment is continued under the evaluation of the oncologist. But nowadays, the oncology can take upper hand to some extent in some advanced malignancy or early malignancy. In that cases, they are more prone to prescribe new adjuvant chemotherapy. That means the chemotherapy is given before doing the surgery. So after giving the chemotherapy, by looking at the endoscopy pathological reports, do the chemotherapy, give the chemotherapy after complete 2 or 3 or 4 cycle, then after 1 month interval, go for surgical treatment. In that cases, they are claimed that the surgical prognosis is more better. It causing localization of the tumor more, so the surgical outcome is better. So the preparation of the patient first, that means the patient having a cachectic anemia, so you need to evaluate the nutritional status, correct the nutrition status, correct the anemia, correct the hydration, and prepare the stomach to declining the edema, because whenever there is obstructions, the stomach needs more work. So where there is more work, there is more trauma, more inflammation, so there is a mucosal wall become edematous. Because the food residue is there, irritate the stomach, there is more edema there. For that reason, in that cases, needed to put an nasogastric tubes, suction, clean the stomach, do the suction and gastric lavage, decline the edema 2 to 3 days, then you go for surgical treatment. So that pre-operative preparation, correction of anemia, nutrition, fluid and electrolyte balance, stomach preparation like stomach wash, prophylactic antibiotic as achlorohydria gastric lumen allows, in case of carcinoma stomach, there is achlorohydria. So there is a more chance of colonization of the Streptococcus faecalis, bacteroids, Staphylococcus aureus. So prophylactic antibiotic may prescribe, and needed to blood transfusion, fresh frozen plasma may be needed pre-operatively and for surgery. And for surgery, particularly gastric surgery, always need for blood transfusion. So sometime ask in the exam, tell me some surgical condition where needed blood transfusion. Where needed blood transfusion. So it is one of the causes: carcinoma stomach surgery, carcinoma colon surgery, and these two things must needed to always need blood transfusion during perioperative and postoperative mandated. Stomach preparation, 3 days preparation. Nothing per oral, IV fluid, the dextrose aqua, DNS, normal saline hartmann solution according to electrolyte imbalance and fluid balance needed. Necessary tube suction and lavage. The suction is a very important thing is written there. 200 ml normal saline every 2 hourly until clear fluid comes out. Initially, when the patient present to you in your department, admitted in the surgical ward, the patient already ingested 4 days, 5 days residual food materials there. So these are the big food materials, big amount is there. So after giving the rice tube, immediately it is not possible to came out all the things through the rice tube immediately. For that reason, the 200 ml normal saline every 2 hourly gastric wash is needed. But in the previous book written, in that case, first do the stomach wash. That is a big tube is given inside the stomach, empty the stomach, then put your rice tube and gastric lavage. But stomach tube is a very hassle for the patient, very painful situation. For that reason, we are not routinely practiced with the stomach wash with the stomach tube. We routinely practice nasogastric tubes. And if you put some normal saline there, the food materials become more liquefied and ultimately become expelled out by giving the suctions. That is 200 ml normal saline every 2 hourly until the clear fluid comes. Whenever the clear fluid comes, then no need for 2 hourly, then 6 hourly, 1 or 2 days you can push, wash, and that causing, whenever the stomach is rest, so the stomach size become to some extent declining, and the rest causing declining the inflammation, so there is the edema become decline, and the tonicity, whenever the stomach is to some extent dilated, the tonicity is less, so the tonicity can regain. So aim of stomach preparation before surgery, it reduces the edema of the stomach wall, improves gastric emptying time by increasing the gastric muscle tone. What about the surgery? The surgical resection is the mainstay of treatment, is the only curative option. Curative surgery depends on the site of the tumor. If the tumor in the lower part of the stomach, that is the pylorus or antrum, then it is subtotal gastrectomy with Rho and Y gastrojejunostomy, or partial gastrectomy with Rho and Y gastrojejunostomy. But if the tumor is a cardiac end, so in that case, or in the fundus, it is radical gastrectomy, that means total gastrectomy with Rho and Y esophagojejunostomy. So be careful about it. Whenever the distal part of the stomach removed, so menastomas is made with the stomach with the jejunum, so it is called the gastrojejunostomy. When the total stomach is removed, so there is no stomach, so in that case the jejunum is attached to the esophagus, so the name is esophagojejunostomy. And another one is endoscopic mucosal resection for early gastric cancer. It is very popular in Japan because they are diagnosed early. They are diagnosed early by doing an ultrasonography. In that cases, so carcinoma involving the mucosa, they are having some fluorescent dye injected into the patient, and after that they do the endoscopy, and that fluorescent dye, whenever in the malignant cell taken the fluorescent dye, the endoscopy can easily diagnose that area is suspected for early gastric cancer. But that cancer diagnosis biopsy taken is very difficult. For that reason, in there is no ulceration is there. By a naked endoscopy, you've never ever seen it is malignancy without inject the dye. So whenever they inject the dye IV, that fluorescent dye taken up by the malignant cells, it is visualized during endoscopy. So that area biopsy taken is very difficult. For that reason, whenever the diagnosis is there is suspected area of malignancy, in that cases they inject some subnormal saline in the submucosa of the stomach at the suspected site of malignancy. So the mucosa is elevated, then he can easily take the biopsy from the site, and the histopathology can easily take it for histopathological examination. So this is the specialized technique. In Japan, they do it for early gastric cancer because they are routinely examine the patient with the endoscopy after the age of probably 40 years. They routinely, every year, they do the endoscopy for evaluation, is there an early gastric cancer or not. So this is the specialized technique of biopsy taken for advanced early gastric cancer. And that early gastric cancer surgery done without laparotomy, without laparoscopy, with the endoscope. Just they can remove the mucosa by an endoscopy, which is called endoscopic mucosal resection. So palliative treatment. Palliative treatment in case of patients suffering from symptoms of obstructions or bleeding. So whenever some patient present to you, they very lately ascites, or some patient present to you with a cardiac end of the stomach, the patient is not capable to anything is anything is ingested is not possible. So in that cases, for if the patient is not possible to do surgery, in that case we need to survive the patient to few days or few months. So by giving them nutrition, so we can do some palliative bypass. That means we can do a gastrostomy or the feeding jejunostomy to survive to some days or months by maintaining the nutrition. But in case of cardiac and pyloric end of the stomach, in that case we are having some scope to make a surgical bypass. So we can do a gastrojejunostomy proximal to the obstruction. So the food matter is diverted and the patient may survive to some extent or some days by the bypass surgery. And some patient may having in advanced country, they are putting some stent in the pyloric end, they are putting some metallic stent there. So that metallic stent can prevent further in growth of the malignancy inside the lumen. So the luminal patency can maintain, the patient can survive few days or few months to maintain the nutrition by through the stent. And some centers they do some canalization with the laser ablation of the tumor mass, make a channel and put some stent there. So these are the palliative tumors, palliative management of malignancy of the stomach. So the stomach having some malignancies there whenever the lesion in the antrum. So whenever lesion in the antrum or the body, you do the subtotal gastrectomy. So most of the stomach is divided, cut here and remove all the tissues along the greater curvature and lesser omentum, greater omentum, lesser omentum, and remove it out. So there is two end, one is the upper end and lower end. The lower end is closed, that means duodenal stump. The duodenal stump is closed, and the upper end is attached with the jejunum. So that jejunum is carried from the jejunum, there you can divide it there. So that proximal and this B is the proximal one, is the distal one. So distal one go up, distal end of division go up and ostomy is the stomach. It is gastrojejunostomy. And proximal end attached with the jejunum. So the bile and the pancreatic juice migrated there and go there. So this distance from here to there, it is at least 25 centimeter. Better to do 40 centimeter or 35 to 40 centimeter is distance from that end to that end. So that end, if it is a 40 centimeter, so it is better because there is a less chance of migration of the pancreatic juice and bile go up and go there. But if you make an anastomosis that end here, so it is every possibility to migrate to the stomach. There is a reflux of bile in the there, irritation of the bile. There is a more discomfort of the patient. For that reason, rho and Y gastrojejunostomy is better for prevention of biliary gastritis. So the proximal is preserved and the blood supply being derived from the short gastric arteries. Only the proximal fundus is and other from the esophageal supply. So this is about the radical gastrectomy. So whenever there is no remnant of the stomach, so whole of the stomach is removed. So it involves en bloc removal of the entire stomach, including the greater and lesser omentum. It also involves the clearance of the regional lymph nodes. So whenever the whole stomach removes, so then the esophagus is anastomosed with the jejunum. So it is called the Rho and Y esophagojejunostomy. So there is a picture there, state the end-to-end is anastomosis. Sometimes the jejunal end is make a loop U. So that top is attached here. So that loop is acts as a reservoir of the stomach. These are the alternative procedures. So look, that is Rho and Y esophagojejunostomy. Hands when anastomosis there. The jejunum is passing behind the colon. So it is retrocolic esophagojejunostomy. Behind the colon, for that reason name is retrocolic. And here the anastomosis is done with a stapler device. So in case of stapler device, the stapler is enters through the end, free end, that tip is there and will attach there, then make a fire and make an anastomosis. This is stapler anastomosis. This is hand swell, stitch is there. So this is palliative procedure. Whenever the antrum obstruction, carcinoma antrum, and there is a metastasis, so in that case the jejunum only attached with the stomach. So gastrojejunostomy is a palliative gastrojejunostomy. This is the picture of the Billroth 1 and Billroth 2 operation and Rho and Y. So Billroth 1 enterectomy gastrojejunostomy. Billroth 2 usually done the Billroth 2, that means partial gastrectomy with gastrojejunostomy, or Rho and Y gastrojejunostomy. Whenever the stomach directly enters the jejunum without Rho and Y, it is called the Billroth 2. This is Billroth 2 and this is Rho and Y gastrojejunostomy. So alternative procedure of surgery, which is usually not done, it is a very important, fantastic thing. So a loop of a segment of jejunum is divided with the vascularity and migrated up and make an anastomy with the esophagus and the duodenum. Or make a loop there, make a fundus-like appearance and make an anastomosis. But nowadays this procedure is not done. It is an alternative one. So the picture, the video is short subtotal gastrectomy. Look.
In Roux-en-Y gastric bypass, the surgeon creates a small pouch at the top of the stomach. The pouch is the only part of the stomach that receives food. This greatly limits the amount that you can comfortably eat and drink at one time. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. Food flows directly from the pouch into this part of the intestine. The main part of the stomach, however, continues to make digestive juices. The portion of the intestine still attached to the main stomach is reattached farther down. This allows the digestive juices to flow to the small intestine. Because food now bypasses a portion of the small intestine, fewer nutrients and calories are absorbed.
So this video is a total gastrectomy. So endoscopically by stapler you divide the GG junction, then stomach junction, esophageal junction is divided partly and give a stitch there. It's very important thing. If we completely cut, the esophageal string go into the stomach, thorax. For that reason, after complete division, they make a stitch suture there, then complete the one. So the genome is divided. It is laparoscopic procedure. The incomplete end through this incompleted enters the endostabulum and make an anastomosis with the esophagus and jejunum. Then the opening is closed with 3 stitches there, then make an stapler. So cut the end, that is sealed. So the gastrojejunostomy, esophageal is completed. The proximal end of the jejunum is then make an anastomosis with the jejunum end to side with a stapling device. So this is the laparoscopic procedure for Rho and Y esophageal total gastrectomy with Rho and Y esophageal. So sign of inoperability. Sometimes ask in the exam, particularly those who are achieved more mark, better mark, in that case sometimes ask, or in post-graduation exam sometimes ask. So inoperability assessed by fixation of the pancreas or posterior abdominal wall or involvement of the mesentery, especially the origin of the superior mesentery vessels, gross local involvement of the lymph nodes, the presence of secondaries in the liver, peritoneal seedling either locally or in the pelvis. All are inoperability of carcinoma stomach. So lymphadenectomy is very important one. In case of D1 lymphadenectomy, perigastric lymph nodes, station 1 to 6, there is conservative node dissection. So D2, whenever D1 plus left gastric, one step proximal. So left gastric, common hepatic, celiac and splenic nodes. Whenever excised, this is D2. It is extended lymph node dissection. D3, all the D1 and D2 plus hepatoduodenal, retropancreatic and splenic nodes, whenever removed, then it is called a D3. And D4, D3 plus paracolic and para-aortic lymph nodes. These are extended node dissections. So according to the dissection of the lymph nodes, it is designated as a D1, D2, D3, D4. So these are the specimen which is sent after histopathology, after operation in the specimen preserved and sent like this manner, mark all the lymph nodes groups, which groups the lymph nodes are you excised, all the marking that can dictate you how far the clearance is. If the 12A node is metastasis there, that means you are not achieved radical surgery, because beyond this may be needed, may remains there. But if that specimen dictate that the metastatic cells found in the 3 and number 7, so the 9 and 12 are clear, that means all the distal can clear. So for that reasons, all the groups of lymph node needed to level and send for histopathological examination. Then you follow up the reports and you can achieve how far the surgical treatment is done, curative or not, by observing the histopathological reports. So other treatment modalities, radiotherapy, routine use is controversial. Usually carcinoma stomach and radiosensitive. It has a role in the palliative treatment for painful bony metastasis. Chemotherapy, very important one. Neoadjuvant chemotherapy provides a great outcome following surgery. Chemotherapeutic agents include ECF, sometimes asked in the exam, E for epirubicin, C for cisplatin, M for 5-fluorouracil. This is a common regime. There is a lot of other regimes for advanced center where there is a more costly drugs can prescribe. There are a lot of options there, but it is a very commonest regime is ECF. So sometimes asked in the exam, epirubicin, cisplatin, 5-fluorouracil. Sometimes in the written question, write some 3 or 4 chemotherapeutic agent name. So for that reason, it also you must know the names are. What about the post-biotic complications? So all the complications where there is an anastomosis, there is a chance of bleeding. Where there is anastomosis, there is chance of bleeding. So the early is anastomotic leakage, esophageal leakage, or duodenal stump leakage. And that is very important one is duodenal stump leakage or duodenal stump blowout. So the closure of the duodenal stump is very meticulously needed to do If it is unhealthy, in that cases we can prophylactically, we don't close the stump, we just put a Foley catheter there and make a control fistula in the outside. So whenever you make a control fistula, there is a collagen tissue deposition from the duodenal stump to the parietal wall, and after subsequently 2 weeks, whenever you remove the Foley catheter, the tract becomes obliterated, there is no chance of leakage. So where there is chance of unhealthy duodenal stump, never ever go for closure. You make a control fistula with a Foley catheter. So in secondary hemorrhage from the exposed or divided vessels, fistula from the stomach, gastric jejunal, periduodenal collection maybe, early or biliary peritonitis during the dissection of the lymph nodes, you may include the biliary tree, which is ignored during surgery. Subsequently, there is a chance of biliary leakage in the peritonic cavity and presented as a biliary peritonitis. And lately, dumping syndrome, diarrhea, nutritional deficiency, that means iron deficiency anemia, because there is no stomach, no intensive factor, there is a less chance of development of iron deficiency anemia. So nowadays very favorite and very common tumor is presented nowadays, which is called the GIST, gastrointestinal stromal tumor. Gastrointestinal stromal tumor. It is not tumor. The tumor is not arise from the epithelium of the stomach. No. GIST may arise in any part of the gastrointestinal tract, but 50% will be found in the stomach. From the stomach to the rectum, anywhere it may develop the GIST, but 50% chance in the stomach. They are tumors of mesenchymal origin. These tumors are thought to arise from the intestinal cells of Kajal. Sometimes asked in the exam, from which cells the GIST is developed, intestinal cells of Kajal, and it is a mesenchymal origin. It is a rare tumor of GI tract, 1 to 3% all GI tracts, rare tumor, 1 to 3%, site of GIST, stomach 50%, small bowel, colon, omentum, mesentery 7%. So clinical features, GIST are usually asymptomatic because usually they are exophytic, that means protruded outside the lumen of the GI tract. So whenever it is outside the lumen protruded, there is a less chance of development of luminal narrowing. So there is a less chance of obstructive symptoms. So are usually asymptomatic and discovered on an endoscopy or at laparotomy or other investigation during other investigations. With advanced disease presented may be mass lesions or vague abdominal pain, GI bleeding due to the ulceration of the mucosa. It is important one, very important one. Some patient may present with a simple GI mucosa ulceration which causing bleeding. 50% GIST may present as metastatic disease to liver and peritoneum. Not all GIST are benign. Some are malignant. 50% GIST may be malignant, which metastasis to the liver and the peritoneum. Metastasis to the lymph node is uncommon. So carcinoma stomach metastasis mainly to the liver, mainly to the lymph nodes. But in case of GIST, it is metastasis to the blood-borne metastasis, liver, peritoneum, etc. Investigation, upper GI endoscopy. Endoscopic ultrasound, it is very important function. Tools of investigations to diagnose the GIST, endoscopic ultrasound, CT scan, and immunohistochemistry. Whenever you take the biopsy, that biopsy is CD34, that means immunohistochemistry done. If it is positive, then your diagnosis confirms 60-70%. It confirms that it is GIST. And PET scan, it also an important role. So look, in the GIST, the mucosa is very normal in appearance. There is no ulcerations, no irregularity of the mucosa. So the lesion is beneath the mucosa, within the muscle there. So GIST diagnosis is most likely it is GIST or it could be a lipoma of the stomach. That are the two diagnoses made whenever do an endoscopy. But whenever do an ultrasonography, by the luminal ultrasonography, endoluminal ultrasonography, you can differentiate is it a lipoma or is it a GIST. You can easily demarcate by looking the ultrasonography findings. So look at the picture of the CT scan. Look at the picture. So these are the differentiation of endoscopy of the ultrasonography, CT scan, findings of GIST. So these are the normal some picture that is taken whenever I doing the cholecystectomy. This is the stomach. So look, there is the arterial arches there along the lesser curvature, along the greater curvature. So look, angular incision is there. By that you can demarcate where the antrum, where the body, where the fundus. So these are the pictures of a normal stomach. And here the pancreas is protruded through the lesser curvature, which is covered by lesser omentum. Whenever we do the surgery, we enter in the lesser sac by dividing a line, dividing the omentum. Here, the colon and the stomach and colon, the greater omentum is fused together, which is called the Poch's line. In the Poch's line, we divide, then we can easily enter into the lesser sac. Because this is the greater sac view, the lesser sac is behind the stomach. So this is about the stomach pathology, malignant lesions, neoplasm of the stomach and bleeding GI tract. So now the session is open for question and answer. Do you have any query or questions? Please ask now.
Assalamualaikum, sir.
Islam?
Sir, how can the patient survive after total or radical gastrectomy? Because he cannot metabolize protein.
Yes. So the stomach is needed for the mainly for the acid, but other juice like amylase, lipase, and tryptophan, that all are things are coming from the pancreas. So the pancreas remains there. The bile is coming from the liver. So these two things are capable to mix with the food materials. Only the hydrochloric acid is not there. So for that reason, he can survive by metabolize the all carbohydrate, protein, fat by pancreatic juice. But there is a stomach is not available there. So there is every possibilities of reflux of food contents from the jejunum to the esophagus, and always there is chance of regurgitation of the food materials to the respiratory tracts. So be careful after total gastrectomy in the post-operative period. Some patient having more cough, more irritated cough due to the aspiration to some extent of food materials into the esophagus and into the trachea. But the patient can capable to survive by maintaining the digestion of the food materials with the pancreatic juice and the bile.
Sir, the absence of pepsin, pepsin doesn't affect here.
Affect to some extent, but the patient can survive. The digestion is not equal with the normal individual, but the patient can capable to survive because whenever there is no stomach, the intake of the patient is declining. It's not possible to more voracious eating because the stomach size is smaller by a small tube of the jejunum. So a small amount of feeding repeated he can take, he can digest easily. Am I clear?
Yes, sir. Thank you.
Any more? So if there are no question, so we can rest for 14 days, 2 weeks for revision. All the things those who are teaching here last few days, so you can read from the books, from the lectures, you can prepare yourself for the exam. And after 2 weeks, again we can discuss the new topics later on. So thank you everybody. Thank you for patient sharing.
Thank you, sir.
sir.
Assalamu.
Assalamu alaikum.